نبتدي جلسة البرونكولوجي النهارده الخميس 3 ديسمبر، وأول محاضرة عندنا من أليس روزمان.
Mr. Alice Rosman, Professor
Alice Roseman, yeah. He is the first speaker, and he's going to enlighten us about the combined EBUS, EUS approach, diagnosing and staging. Dr. Roseman is from Slovenia. And is this your first trip to Egypt, or you have been here before?
No, I've been here before, but as a tourist, not as a as a lecturer.
So we're happy to have you with us.
Thank you very much. So, dear Chairman, dear colleagues, thank you very much again for the invitation and for the hospitality. And of course, I'd like to congratulate for this very, it seems now, very successful Congress with a high quality of the lectures and so on. Since my time is running, I'll just start with the EBUS and ESSb approach in diagnosis and staging of the lung cancer. So I'll try to answer several questions during this lecture. The first one is, why is staging of lung cancer important? Well, we all know that it's important, but just in a few words, that if we stage patient properly, we treat them properly. Some go to surgery, radiation, and chemotherapy, whatever, according to the stage of the disease. Then the staging also has the prognostic information about survival, about other things. If we do some downstaging in N2 disease or even N3 disease, we are able to restage the patient after therapy as the evaluation of therapeutic response, and we can select the patients to including them in different clinical trials. How to plan staging? Initially, we do non-invasive procedures like CT and PET-CT. According to that, we classify patients in several groups. I'll show them later, and after that, we select the most appropriate diagnostic tests. So, in which patients we do the invasive staging? Here are 4 groups of patients according to CHEST 2013 meta-analysis, and we have on both sides very different types of patients. The first one, we already see, these are all patients without distant metastasis, because in distant metastasis we don't do staging in mediastinum. These patients have obvious malignant infiltration of mediastinum. It's a bulky mediastinum, infiltration of several vital areas, and in these patients we don't do staging. It's not necessary because we already know that the disease is widespread. In the 4th group of the patient, according to CHEST 2013, we don't do the staging in the group of patients where have a small peripheral lung tumor and no lymph nodes anywhere enlarged. Even in the hilus, even in the mediastinum, if there are no enlarged lymph nodes, in this group was considered that we don't do the invasive staging, except if we have PET positive lymph nodes. If we have SUV about 2.5 in certain lymph nodes, then we take a puncture from them. But these 2 groups, B and C, are tricky. Group B has enlarged mediastinum lymph nodes, but we can see that a lot of them are false positive. According to CT scan, 40% of them are false positive. Patients have some conditions which are going together, like pneumonia or some infection and so on, and they have enlarged lymph nodes. They are not necessarily malignant. The group C is group where we have either centrally located lung tumor or we have N1 enlarged lymph nodes, but we don't have enlarged N2 or N3 lymph nodes. It means mediastinal lymph nodes are not enlarged, but hilar lymph nodes are enlarged. In this group, it's the problem just opposite. We have a lot of false negative results, even with CT and even with PET-CT. And again, here we need to do invasive staging. But according to the new recommendations from ERS published this year, we have 2 additional group of patients where we also need to do staging. The first one is patients with small tumor, peripheral tumor, smaller than 3 centimeters, which is PET negative, but proven malignant. Then we also need to stage mediastinal lymph nodes, even if they're not enlarged. And the other condition is when we have peripheral tumor bigger than 3 centimeters, regardless if it's PET positive or negative, we also need to stage mediastinal lymph nodes, even if they are not enlarged. So the first question, how to select the appropriate diagnostic tests? We need to be sure when we send patient to surgery that the lymph node is really negative, that it's not malignant. So specificity and sensitivity don't tell us a lot. The value which tells us most is negative predictive value. This is the value how sure we are that the lymph node is really negative after our puncture or after evaluation. So here we can see that CT scan is not reliable. PET scan is a little bit more reliable in combination with CT, but around 90%. This means that around 10% of lymph nodes are still there, which are not recognized. And again, there are some other problems with non-invasive methods that have also false positive cases, and they can be also mistreated because of that. Mediastinoscopy has 91% of negative predictive value, and combined EBUS and EUS 96%. So it means in this case, according to that meta-analysis, the EBUS approach is superior to this one. But what if you use just EBUS TBNA without EUS? We are bronchoscopists, we do bronchoscopies, we put EBUS in the bronchi and so on. Why to ask gastroenterologists to make another procedure? We just spend time and resources, and how accurate is just EBUS TBNA? We see at the end negative predictive value of EBUS TBNA is 91%. This is, according to previous slide, the same as mediastinoscopy, but we're not satisfied very much, because if we add EUS, we get another 5%. And why we don't do mediastinoscopy as the first method of staging? Well, we all know that's the invasive method. Is there any thoracic surgeon in the hall? Okay, no one, so I can speak more invasively now. Basically, we need general anesthesia. The method is invasive, and of course, it consumes a lot of resources. It's more expensive than EBUS TBNA, and the most probably it's not so accurate. The classic mediastinoscopy has negative predictive value 91%. Video assisted mediastinoscopy has a little bit higher, and here we have lymphadenectomy. This is like VAMLA or TEMLA, but the majority of the centers don't do that because some limited number of data. This method is very invasive because they empty the whole mediastinum. Of course, negative predictive value is high here, but I think that only several centers in the whole world do that, and it's very aggressive. Overall, negative predictive value of mediastinoscopy is around 91%, according to the majority of data who are gathered from the group of classical mediastinoscopy. So, method of choice, the first method of choice is obviously combination of EUS and EBUS with negative predictive 96%. And according to the last recommendation from European Respiratory Journal 2015, this is the first method, recommended method. It's more recommended over the surgical staging, grade A, for doing staging of patients with lung cancer. There's also grade B recommendation that if we are not satisfied with this, or we are not sure that we get appropriate sample, we can still send the patient to mediastinoscopy. But we can ask ourselves, why to send the patient when we did the method with high negative predictive value to the method which has lower negative predictive value? Can we use EBUS bronchoscope also in the esophagus? This was a question for several years already, and yes, we can do that. We just do the procedure in bronchi, into trachea, we puncture the lymph nodes, then we exit and went to esophagus. It's completely feasible and easy to done. And we can also puncture the lymph nodes in stations 8 and 9, and if you can even go a little bit further, the first reports, the left adrenal gland, is also accessible also by EBUS bronchoscope, not just by EUS, through EUS bronchoscope. And right at the moment in Netherlands, one large study was started about in how many patients we can visualize left adrenal gland, and in how many percentage of patients we can also make a puncture of this lymph node. So there were two very nice publications in Chest 2010, just in the same number, one after another. The first one was Fang Bo and his group about using EBUS in the esophagus. So they showed that the procedure is feasible, that the accessibility of mediastinal lymph node stations is increased, and additional diagnostic gain can be might be obtained by using bronchoscope into esophagus. Here we see the numbers. If we just do the normal EBUS TBNA, the negative predictive value is a little bit more than 93%, but if we go into esophagus, the negative predictive value is bigger a little bit. It's not statistically significant, but we can see that it's better than just do in one way. And the next study, in the same number of chest, German study, again, they did esophageal staging with negative predictor value 82%, then endobronchial staging 92%, and when they combined these two, 96% again. So they concluded that the complete staging can be done with one instrument in one session by one operator, very fast, in basically the same session with the same resources. What is accessible with EBUS bronchoscope? Of course, all these lymph nodes, which are very important, mediastinal lymph nodes. If some additional questions arise, we can also puncture the hilar lymph nodes or even some pulmonary lymph nodes. If this is the only way how to get diagnosis, we can then go to esophagus and puncture 8 and 9 stations, and sometimes 4L and 7 are pretty difficult from the trachea. We can also change the position and also puncture these positions from esophagus. It's a little bit more easy and also very good accessible. And left adrenal gland seems to be also accessible to bronchoscope. We can also do the direct diagnosis from lung tumor if it's in the vicinity of the larger airways, either in the vicinity of trachea or the main bronchi, or in the vicinity of the esophagus, again with the same instrument. So, can we use EBUS finding respiration for diagnosis of lung cancer? Yes, we can do. It's nothing new. But this study from Lancet, published this year, is very interesting. So, a lot of centers used in the first round of diagnosis the normal classical bronchoscope, video bronchoscope, and classical TBNA. And when the results were unsatisfactory, they used EBUS in the next session, maybe a week or two later, for doing the complete diagnosis and staging. So it seems that it was a practice in England, in this center where they did this study. So they decided they will use EBUS in the first round of diagnosis, and they will do just one procedure and use the EBUS at the very beginning for getting diagnosis and staging in the same session. So the results were interesting. So they realized that the time from the first meeting with the patients till the treatment decision is shortened. What does it mean? So the red line is the line are the patients where they have EBUS in the first session. Blue line when they have EBUS in the second session. So the time from diagnosis to the treatment decision was shortened from 29 days to 14 days. That's half as much. And what does it mean? This can have a survival benefit. So this is survival 2 years after the initial evaluation. These are patients who are still alive at that moment. And we can see that patient who had EBUS in the first session and who had treatment decision 14 days, 15 days earlier than those who didn't, there's quite a difference after 2 years in the survival. But I'm a little bit naughty, and I showed also here two graphs. These are famous Coyote study when they add one expensive drug to cisplatin and compare it with one more cheap drug to cisplatin. We all know this study about Alimta and gemcitabine. And they proved that there is some survival benefit if they use pemetrexed with adenocarcinoma, and there's no survival benefit if they use pemetrexed with squamous cell carcinoma. But the difference in these curves after 2 years is approximately the same as if we do the diagnosis 15 days earlier. It's interesting. So, and the last question is how to take samples and what to do with them. In Respiration previous year, there was a nice publication about recommendation what to do with samples taken with the needle. So, recommendation was that we need at least 3 punctures per lymph node when we do the staging with EBUS, and a little bit more if we do classical DBNA approach. That it's not really important what size of the needle we use. 19G needle seems to be not superior to 21 or 22 gauge needles, but it's more likely that we get histology. Whenever possible, take enough sample to get cell blocks and additional immunohistology and subclassification. Even mutations are possible to be done from cell blocks. And if we plan to take cell blocks, we need at least 4 passes per lymph node. Rows, it's useful, but we cannot prove this in clinical studies why we so like it. We all know, but that if we have immediate confirmation that that the material is okay, it's very good. But it's still not proven if this is recommended for every procedure. So my conclusions are: it seems that I'm right on time. That with the standard staging of lung cancer patients, we can safely use and choose EBUS tBNA and EBUS fine needle aspiration as the first method. Then with the stenoscopy, if you're not satisfied, and these are basically my conclusions. Thank you very much.
Thank you, Professor Ellis, for this fruitful lecture, and allow me to introduce Professor Semra for the next speaker, who will talk to us about the rationale for effectiveness and safety in interventional bronchoscopy.
Dear colleagues, Masa El-Hiyar, I hope I'm pronouncing it correctly. It's again pleasure to be talking in front of you again. In safety and quality in interventional pulmonology, one of the important pillars is education and training in this field. The education and training should be structured, innovative training of the whole team, and it should be done in centers of excellence with high volume of training. There should be faculty development programs, because the faculty training the trainees should also be trained, and there should be good train-the-trainer courses and programs for this purpose. And there should be state-of-the-art research. Unfortunately, in interventional pulmonology, there are not so many state-of-the-art researches done. This number should be increased. Guidelines should be evidence-based, and they should disclose conflict of interests. Again, unfortunately, conflict of interests are not emphasized too much in the studies or research. And there should be quality lessons in education and training. The training and education should be of high quality. And in education and training, simulation or mannequins should be used. The old model of apprenticeship training on patients should be avoided because it increases time, sedation, and complications. And the training, education should be competency-based, not on number-based. In the past, it was said like 50 cases of rigid bronchoscopy enough for every individual. No, every individual is different in learning. So we should emphasize on competency-based education. When the person is sufficiently and competently doing that thing, we can say, okay, you can start doing it. Validated assessment metrics should be used when we are educating or training. So the training should be objectively measured. And there should be evidence-based, standardized curriculum in education. And there should be research infrastructure by funding or support by different departments or health ministry or other sources. Situational awareness is another pillar in interventional pulmonology. What is situational awareness? Perception within a volume of time and space, plus comprehension of the situation, plus projection of this in near future. So you understand it, you perceive it, you understand very well, and then you use your experience and knowledge for future experiences. This is situational awareness, and it's very important in interventional pulmonology department because it prevents disasters in high-risk environments and during crisis, and this is encountered in interventional pulmonology units so many times. There should be personalized management in IP. The Most ideal management regarding patient, hospital team, experience, equipment, and budget should be used. And there should be detailed risk potential benefit analysis. I'll give you an example. The patient may be in respiratory failure due to a malignant tumor occluding the trachea. And you may be thinking of risks of the interventional pulmonology procedure, but maybe that patient would benefit the most from the interventional pulmonary procedure. You have to weigh the risk and the benefit. Sometimes the most dyspneic and risky patient may be the most benefiting one. You have to consider all these before the procedure. Validation of outcomes is important in safety and quality in interventional pulmonology. You should validate your outcomes immediately after the procedure, but that is not enough, because that is only technical success. You should further go in the first month, maybe third month, and sixth month, see the results, the outcomes, because follow-up is important for long term. How do you do it? You can use exercise capacity, 6-minute walk test, lung function by spirometry, quality of life measures, appropriate questionnaires such as for dyspnea, cost effectiveness, cost savings per day, and then don't forget, only statistical importance is not important. Clinical plus statistical importance is beneficial. In studies, most of the studies, they say it's significantly statistically important, but that by itself is not enough. Quality is another important pillar in safety and quality in this field. Quality should be in interventional pulmonary team, multidisciplinary team. We are not by ourselves. There should be thoracic surgeons, oncologists, radiation oncologists, ear, nose, throat surgeons, infectionists, pathologists. So the whole team should have good quality. Quality should be in the equipment, logistics, and IP procedures. And these procedures should have assessment of risk-adjusted disease-specific outcome. Quality of life in our procedures is also important. It's also important in research. We should include we should include quality of life in study endpoints, and appropriate questionnaires should be chosen to measure quality of life. Cost effectiveness for any country, even for rich countries, is important. We can buy a lot of instruments, but is it worthwhile to buy all of them? Buying laser, electrocautery, e-bus, electromagnetic navigation. You should choose the most cost-effective ones for your own department. Not every department is the same, but even for the rich ones, they should make this cost-effectiveness evaluation. So what is cost-effectiveness? Potential benefit at some cost. So be careful. You have to know your priorities in healthcare expenditures. Cost per symptom-free day with no emergency visit, cost per day with no expensive ICU care, these are important. And cost effectiveness should be in new technology. You shouldn't buy everything coming out. First, consider the cost effectiveness. Is it really needed? What will you have if you have that new instrument? Infection control, I won't go deep into detail, but infection control in the interventional pulmonology unit is important for the staff, for the patient, for the whole hospital. You should have enough adequate ventilation, negative air pressure, particulate air infiltration, disposable bronchoscope suction valves, manually cleaning equipment before disinfection, controlling patient coughing, that is important, prophylactic antibiotics in some cases, barrier clothing, and needle stick precaution. Maybe many more, but infection control is a very important issue in the field. Reprocessing of the instruments. Most of the time, infections spread through IP instruments are unrecognized and unreported, even in the researchers. So we should have team vigilance, protocols, collaboration between IP team, infectious team, and manufacturers. And we should follow guidelines for infection or reprocessing and clean and disinfect each case, clean and disinfect per case. Every patient is different. Maybe that is an infectious patient, the other a lung cancer patient, but we have to be careful. Radiation safety, most of the time fluoroscopy is used in IP units, and this is the chief source of radiation exposure. And it's interesting that non-radiologists receive more radiation than radiologists, because radiologists know the issue and they protect themselves. So cumulative radiation exposure is important. We should have measures for monitoring radiation, and measures to reduce radiation. This table is important, and it summarizes whatever I'm trying to give to you. It has 4 sections: patient-centered practical approach, initial evaluation. You should initially evaluate the patient with detail. What does it include? Physical examination, complementary tests, and functional status. Patient's significant comorbidities, patient support system, patient preferences, expectations including the family. The second box, we are coming to planning the procedure, procedural strategies and planning. Indications, is it really indicated? You can do it, but is it really indicated? Does the patient need it? Contraindications and expected results. Operator and team experience and expertise. Risk-benefit analysis, weighing the risk and benefit, and therapeutic alternatives. Respect for persons, informed consent, and ethical issues. This is also important nowadays. We have many patient complaints. You have to protect yourself too. And the third box, now we are coming to the procedure. Procedural techniques and results. Anesthesia, other perioperative care, techniques and instrumentation, anatomic dangers and other risks. Anatomy is very important. You have to know the anatomy, relationships of the organs with the lung, airways, vessels. If you don't know anatomy, don't go and dare to do bronchoscopy or interventional pulmonology. Results and procedure-related complications go into this box. And then long-term management plan, outcome assessment, follow-up tests, visits and procedures, referrals to the medical, surgical, and palliative end-of-life care subspecialty, and then quality improvement and team evaluation of clinical encounter. So this should be in your unit all the time. You should have this algorithm before doing your procedures. And you should have a checklist for any IP procedure before starting to do your procedure. Because we are human beings, we are doctors, but we can be sleepless, we can be careless, we can have mistakes. Not to have many mistakes or just completely get rid of them, you should have a checklist to fill it out before the procedures. And it includes all the important points so that there are less complications, you are beware of any detail about the patient. And when we are doing interventional pulmonary procedures, we should always ask, is this situation life-threatening? If it's not life-threatening, you can use flexible bronchoscope. If it's life-threatening, you should use rigid bronchoscope to take care of the patient well and also to protect yourself too. And if the patient is not having life-threatening situation, after doing flexible bronchoscopy, you consider whether the patient is operable. If not, you can ask if the patient is symptomatic. Not every patient needs interventional pulmonary procedure if they are not symptomatic because of that disease or the disease you are trying to treat with interventional pulmonology. More than 50% of airway obstruction, most of the time, is symptomatic, but not every patient. So just think, is it symptomatic? Is there indication for doing interventional pulmonary procedure? And then you can combine radiotherapy, chemotherapy with these interventional pulmonary procedures. And another important point, is your lesion intraliminal or extraliminal? Because the procedures completely change. Sometimes they are mixed. You have to combine stenting for extraliminal component and also electrocautery, laser, or other endobronchial treatments for the endoliminal component. And please use silicone stents for benign disease, because these patients have longer survival. Metallic stents in benign disease causes disasters. You cannot get them out. Maybe surgery needed, sometimes surgery even cannot help. So use silicone stents for benign disease. You can use silicone or metal stents for malignant disease, but metal stents is always for malignant disease. They have shorter survival. And we should always have good algorithm and planning when doing interventional pulmonary procedures. For tracheal stenosis, for example, you have to assess whether it's simple or complex. If it's simple, maybe only interventional pulmonary procedure is enough. But if it relapses, surgery may be needed. You have to consult thoracic surgery for these type of things. Just don't decide by yourself. It's complex, surgery is always needed. But if the patient is not operable, again, interventional pulmonologists should do dilatation, stenting, and follow-up. After 24 months, maybe assess the results. Maybe the stent can be taken out. Whatever is happening, you act accordingly and know your anatomy well. I am repeating this again. This is important. If you don't know the mediastinal anatomy, airway anatomy, lung anatomy, and the relationships with the organs, vessels, airway, don't dare to do any bronchoscopy, even diagnostic. And also don't forget anatomy changes by surgery, chemotherapy, and radiotherapy. Sometimes you don't find whatever you are trying to find in the right place because of these changes. And the complication rate of, in general, the interventional pulmonary complication rate is only 4%. It's not too much. But look at the 30-day mortality, it's 15%. It's published in Chest, it's an important study, and urgent, sorry, I have a few slides left, just a few slides. The most important factors are intrinsic mixed obstruction, stent placement, urgent emergent procedures, redo therapeutic bronchoscopy, and moderate sedation that we see complications or mortality rate high. And another study by Armin Ernst and colleagues showed that mortality rate is 8% within the 30-day of therapeutic bronchoscopy, and the morbidity is 20%. Who has the most complication and mortality? Malignant disease, tracheal disorders, diabetes mellitus, and COPD. So you have to be careful with these patients when you are doing the interventional pulmonary procedures. And this study emphasizes the quality control in medical application in interventional pulmonary procedures. And the whole team should know the all complications and be ready with knowledge, equipment, and technique. You can have complications, it's not zero complications, but if you are ready immediately for managing the complication, the problem won't be too big. There are so many complications. I don't want to scare you, but you have to be knowing that you can have complications and you have to know how to manage them. And the whole interventional pulmonary team, interventional pulmonologist, nurse, assisting personnel should thoroughly know how to run the whole equipment in the department and the safety measures. And my recommendation is be modest in interventional pulmonary procedures. Don't be too pushy, too enthusiastic to get rid of the whole tumor. Just get the airway open or do whatever required in, how you say, minimal amount so that the patient has palliation. Afterwards, you can check and do much more. If possible, combine methods such as debulking, argon plasma coagulation, so that you have less complications. Avoiding continuous application is good because if you do continuously laser treatment, you can perforate because you cannot realize it. Suctioning frequently, the debris, if it's suctioned frequently, is nice. Cleaning probe frequently and close follow-up. The best thing in being a doctor or interventional pulmonary procedures is close follow-up. Even if you don't know everything, if you're a good follow-up person, you will have less complications. Check 1 or 2 days later, maybe 1 month or 2 months later too. Avoid charring when you're doing hot treatments. And coagulation plus mechanical debulking combined decreases the number of complications. My conclusion is there should be a rational, patient-centered, optimal approach comprised of initial evaluations, procedural strategies and planning, procedural techniques and results, and long-term management plan. This is very important. And the multidisciplinary approach with dynamic interaction of pulmonology, pathology, radiology, thoracic surgery, ear, nose, throat doctors, anesthesia, medical oncology, and radiation oncology is important. This is a teamwork. And these are words from Dr. Mehta, and I like those words. For all interventional pulmonary diagnostic and therapeutic procedures, Because it could be done, it doesn't mean it should be done. Lung disorders are international phenomenon, more so in developing countries. Our recommendations should be inclusive of all considerations. Reducing healthcare costs is a civic responsibility. Be aware of the procedure in search of a CPT code. The reimbursement is also important. And the last sentence, no procedure should be performed just to maintain skills, just to satisfy yourself. Is it really needed? You have to answer that. And I want to announce the 4th European Congress for Bronchology and Interventional Pulmonology in cooperation with Turkish Respiratory Society that will be done in April 2017, Çeşme, Izmir, Turkey. I invite all of you to this meeting. This is a lovely place, plus the meeting, I promise you, it will be a nice meeting. And also, we decreased the membership fee of European Association for Bronchology and Interventional Pulmonology. As you see, EABIP membership has become 20 euros by itself. If you add this, add to membership, WABIP membership, it becomes 40 euros. And if you want to add e-JOBIP, it's $35, and e-respiration, 65 euros. So we changed the other membership, the previous membership, because you had to have respiration together with the membership. You don't need now. You can just become an EABIP member with 20 euros. Thank you for your attention.
And thank you so much, Professor Semra, for your comprehensive talk about the safety. Now, unfortunately, we started half an hour late, and we only have an hour before the next session to start. I'm asking 4 speakers to try to squeeze their talk in half an hour. I don't know how this will be done, but having said that, I will introduce Professor Muhammad Khairi. He's going to talk to us about the sequential use of cryo extraction post-electrocautery for airway recanalization via fiber optic bronchoscopy. Please proceed.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman, dear colleagues. I will go rapidly to summarize as Professor Ala said. My talk is sequential use of cryo-extraction and electrocautery for airway patency via fiber optic bronchoscopy. As you know, rigid bronchoscope is more easier and safer than fiber optic bronchoscopy, but not everyone can do it. So my talk about central airway obstruction by electrocautery and cryo extraction after electrocautery. Central airway obstruction can be caused by malignant and benign tumors as foreign bodies and granulation tissue. Endobronchial electrocautery refers application of heat produced by high frequency electric current to destruct what is present inside the airways. Cryo-extraction is performed to stick to the destructed tissue and extract it through fiber optic bronchoscopy by 2 methods will be mentioned later. My study included 2 groups, benign group and malignant group. Group A, non-malignant, included 8 patients with benign tumors, granulation tissue, foreign bodies, and so on. Malignant group included 14 patients with malignant tumors with non-small cell lung cancer and 1 case with endobronchial lymphoma. All patients evaluated clinically with symptoms and signs as cough, hemoptysis, collapse, quality of life, and radiological evaluation with CT and X-ray, and pulmonary function. Diagnostic bronchoscopy was done firstly to diagnose what's in, and later on interventional bronchoscopy was done to destruct and extract the tumor inside the airways. Number of sessions were according to the cause of the tumor, the cause of obstruction, and the extent of endobronchial obstruction, and the patient response. Interval between each seizure was 2 weeks to allow the dead tissue to be friable and extracted later on with cryo. Electrocauterization is a cheap, this cheap apparatus about $1,000 US, and can be used for about 1,000 patients safely. Energy used about 70 watt spray mode. Application for each shot about 3 to 4 seconds till debridement of the obstructing lesion. This is a cryo apparatus about $10,000, and you can do many cases. So the cost of every patient, of every seizure, not exceed 100 pounds per seizure. Cryo extraction was done to remove the endobronchial tumor after debridement of with electrocautery. 2 methods were applied in this study according to the method used. Number 1, to stick the tumor to the tip of the probe and remove the bronchoscope into 2 with the extracted tumor, or leave the extracted tumor in the healthy lobe, what's called catch the tumor, let it to drop inside healthy bronchus, and the patient later on cough, what's called CDC. Follow up of the patient according to the symptoms, clinical signs, and radiology, and pulmonary function. There is objective evaluation of the endobronchial obstruction according to the Spicer obstruction scoring and revised RECIST. Good response or partial or no response or progressive disease according to the equation, more than 50% increase in the caliber of the lumen. It's called good response. Partial response, 25 to 50% increase in the caliber. Less than 25% increase in the caliber of the lumen. It's called no response, or progressive increase in the size of endobronchial tumor, more than 25%. There is improvement in symptoms, hemoptysis as dyspnea, hemoptysis, cough, intensity, pneumonia severity score, and the performance scale and the quality of life, and the Karnofsky scale before and after therapeutic. In both groups there were significant. Where are the tables? Spirometric parameters before and after the intervention, improvement of the spirometry as FEV1, FEVC, and F1 over FEVC. Tables. شغال ما هي شغالة ماشي Sure. Okay. 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 The case one, can I present 4 cases? Case one, 63 male patient, ex-smoker, progressive dyspnea, hemoptysis, cauliflower mass obstructing the left main bronchus, diagnosed as adenocarcinoma, total lung collapse as you see. CT picture of the same patient. The left main bronchus totally obstructed with a tumor. This is before. This is before and after. And after extraction of the endobronchial tumor that totally obstructing the left main bronchus. The CT before and after. Case 2, 30 years old female patient presented with persistent dry cough for 3 days and hemoptysis with history of pen aspiration. This pen extracted after using cryo extraction. This is the pen after its extraction. This is endobronchial lymphoma. This is the picture before extraction and after extraction. CT before and CT after. This is the endobronchial tumor obstructing the left main bronchus and after cryo and electro extraction. 60 years old female patient with tracheostomy, post prolonged intubation. The granulation tissue was obstructing the trachea totally, or near total obstruction. This is a tumor before and after cryo and electrocautery. My conclusion is electrocautery combined with cryotherapy are safe and effective modalities in alleviating symptoms, improving performance and quality of life, and ventilatory function on patients with central airway obstruction. These modalities are cheap when compared to laser and argon and so on. My advice is every chest department and in every hospital must acquire the electrocautery and cryo for extraction of tumors. It is done safely with no complication and no mortalities in our patient. 22 patients, no case died, but we have 2 cases developed AF after electrocautery as it may cause AF after its use. Thank you.
Thank you, dear Professor Khairi. And now we move to the next speaker, Professor Ashraf Madkour. He will talk to us about bronchoscopic management of tracheal stenosis.
Bismillah ar-Rahman ar-Rahim. Thank you, Mr. Chairman. I'm going to speak about bronchoscopic management of benign and malignant tracheal stenosis. I will be rapid as much as possible. This is my agenda. All we know that the tracheal stenosis is narrowing of the trachea by malignant or benign process. There is controversy of the management, whether it is surgical or endoscopic. This depends strongly on the experience of the center, referral pattern, and the characteristic of the stenosis. We all know the causes of tracheal stenosis. The most common in our country is the post-intubation tracheal stenosis, post-tracheostomy, and malignancy, but we don't have data about post-tuberculous sequelae. We are going to do research in this area. We all know the symptomatology with patient presenting with tracheal stenosis. It may be signs and symptoms of airway obstruction. It may be not urgent or present with acute life-threatening complications. To assess the case, we do flow volume loop, and we can see extrinsic or extrathoracic or intrathoracic obstruction through a full flow volume loop. We have different methods of radiology. The most important is to produce three-dimensional reconstruction or virtual bronchoscopy. Also, MRI can help you to see if there is invasion of the surrounding airways, and this is the virtual bronchoscopy and three-dimensional construction. Flexible bronchoscopy will discover during diagnostic workup unexplained symptoms, may discover tracheal stenosis. It is better to avoid it because it may precipitate acute complete airway obstruction or proximal hemorrhage. Rigid bronchoscopy is preferred because it is diagnostic and therapeutic at the same time. The most important when you have a stenotic segment of the trachea is to assess its length, degree of obstruction, distance from the vocal cords and the carina, the state of the mucosa, the state of the tracheal framework from outside, and the respiratory efficiency. There are different methods of classification, qualitative classification, whether fixed or dynamic obstruction, and stenotic classification and morphological classification. The stenotic classification as regarding the location, which part, upper, middle, lower part of the trachea, or involving the right main and the left main as well with the trachea. The type of the stenosis, exophytic tumors, extrinsic distortion, scar and stricture, saber sheath trachea, floppy membrane, abrupt transition, and taper transition, or the degree of the stenosis as regard the cross-sectional area leading to up to complete obstruction of the airway, and each one which is with its percentage. What's important is the morphological classification, whether it is simple or complex. Simplex means that it's caused by granuloma and web-like with a short segment, less than 1 centimeter. There is the tracheal wall and the cartilaginous ring remain intact and not involved. On the other side, the complex, the tracheal wall and the cartilage are involved. It's more than 1 centimeter. There may be associated with or without malacia. The surgical approach for sure is the best preferred approach for complex benign and resectable lesions with malignant tracheal stenosis, but there are some concern that not all patients are surgical candidates. It cannot be offered for acute situation. There is scarring and recurrent stricture in up to 14%, mortality 5%. Not all surgeons accept this, and not all surgeons are competent to do this procedure. Endoluminal endoscopic treatment lead to relieve threatening symptoms. It leads to direct and dramatic improvement clinically and functionally, but it is suitable for patients who are not suitable for surgery or who experience failure after the airway surgical resection. Bronchoscopic modalities applied through combination of all different methods of interventional bronchology. Up till now, the endoscopic treatment result into improvement in the luminal patency, but there is inconsistent results in literature. The durability need further testing. What about the tumor management? Tumor management of the tracheal stenosis will depend on genetic engineering. This is synthetic scaffold culture. We can get trachea from an animal, and through the genetic engineering, you can culture cell and re-anastomosis with the trachea. Another thing that has been done, successful tracheal replacement in human using autologous tissue. 8-year experience, they remove a flap from the skin in the arm and then get part of the ribs, and then they augment it together. They then put it on to receive blood supply on the arm for a little while through the vessel, the radial vessels here for a long time, and then they transplanted in the lung. This is actually what happened, and this is finally the trachea, and they put it inside the airway. This will be the future. I'm going to present a real original investigation that we've done in Ain Shams, and I presented in the ERS and published in our Egyptian Journal of Bronchology about the role of interventional bronchoscopy in the management of benign and malignant tracheal stenosis rapidly. We aim to investigate the role of intervention in the management of tracheal stenosis and to evaluate the treatment strategies used and the complications encountered. This is our equipment. As Semra said, in interventional and benign tracheal stenosis, if we have simple stenosis, we do interventional bronchology first time, second time. If the condition is stable, we follow up for 6 months. If there is third recurrence, prefer to do surgery if it is operable. If it is not operable, interventional bronchoscopy with or without stent placement. In cases of complex stenosis, surgical evaluation, operable go to surgery and follow up. Non-operable do interventional bronchoscopy with or without stent application. In case of inoperable symptomatic malignant tracheal stenosis, we do, if it's intraluminal, we do mechanical debridement, dilatation, electrocautery argon plasma. In intraluminal extrinsic, we may add stent as well. We take a patient who have first presentation and we follow up the patient after 6 months from the completion of the initial intervention. There were 30 patients with tracheal stenosis, 20 benign and 20 inoperable, and we classified them according to the Freitag classification of central stenosis. As you can see, the majority of the benign cases were in the upper 1/3 of the trachea, while in the malignant cases it was in the lower 1/3 of the trachea. Most our benign lesions were scar and scar stricture, while most our lesions in the malignant were intraluminal lesions. The degree of obstruction, they were tight stenosis in cases of benign and moderate stenosis, a degree of obstruction in malignant stenosis. We have 20 cases of benign, 6 simple and 14 complex. The most common etiology was post-intubation tracheal stenosis. All the cases of simple stenosis received interventional bronchoscopy, while 12 out of the 14 received interventional bronchoscopy. 2 patients were surgical candidates and successfully proceeded to done surgery. The mean procedure per patient in case of simple was 2.8. While the mean procedure per patient in complex was 4.3 procedure per patient. In all cases of simple, 1 stent was applied. In complex cases, stent was applied in 10 out of 12 cases. The therapeutic response, as Professor Khairi said, he have elaborated the response criteria. All our patients have good response, more than 50% increase in the caliber of the lumen. The recurrence of the stenosis in the first 6 months was in 2 cases, 1 simple and 1 complex, and we repeated the therapeutic intervention. There were no mortality or intra-procedural complication. During the first 6 months of the benign series, no mortality occurred. These are the complications encountered or stent-related complications: stent migration in 3 cases, retention of secretion in 7 cases, excessive granulation tissue in 5 cases. What about the malignant cases? We have the malignant cases, the 10 cases. We do all the interventions. In all cases, we do the stent except in 2 cases which we do mechanical dilatation and electrocautery. All the cases produce good therapeutic response at the end of the procedure. The stent-related complication were migration in 1 case, retention of secretion in 3 cases, tumor ingrowth in 3 cases. 2 of our cases died during the first 6 months because of disease progression. They were malignant cases at 3 and 4 months respectively. This is an actual case of web-like stenosis before we do to it interventional bronchoscopy. This is a case of complex stenosis. As we can see, different levels. We do electrocautery, balloon dilatation, bougiaging with the rigid bronchoscope, and finally stent application. This is a case of combined intrinsic and extrinsic tumor ingrowth invading the airway. We do electrocautery, mechanical dilatation, and finally stent application. This is an actual one of our cases series that I'll project. As you can see here, this is a complex stenosis. We do suction, and then we do electrocautery, followed by dilatation. Electrocautery at first, then dilatation with the rigid bronchoscope, as you can see, this is the main carina. This is the situation after the dilatation. Then we inserted the stent and it was folded. Then we tried to open it with the large forceps. Now it is in place, and this is now the airway patent, and the patient can breathe successfully after the dilatation and the interventional bronchoscopy. Conclusion: interventional bronchoscopy procedure applied by pulmonologists are useful option for management of simple, benign, and inoperable complex benign and malignant tracheal stenosis, and are associated with a relatively high rate of non-life-threatening stent-related adverse event that can be easily managed. Further, long prospective studies are needed to address the ideal stent for such patient and to better determine the place of interventional bronchoscopy in the therapeutic algorithm of management of tracheal stenosis. Thank you very much.
Thank you very much for all the speakers for their attention to shorten their lectures so we can accommodate all the speakers. Now, Professor Khalid Zamzam, he's going to talk to us about high definition bronchoscopy.
Thank you, Mr. Chairman. Thank you for attending the session, and we will go quickly. High-definition bronchoscopy is a new era, but it's not very new, starting just before 2000. The autofluorescence, I think, was the first start, and it concluded that epithelial tissue has an innate fluorescence property that is not screenable without some enhancement. And the autofluorescence bronchoscopy airways are illuminated by a narrow range that is 395 to 445, approximately 550 nanometers. But this is not the range of the normal white light. So any reduction in the fluorescence will show some difference in color. It will not be green. It will turn into pink or magenta color. Blood will appear dark green. So care should be taken that some mucus or secretions could make it look falsely pink. Autofluorescence bronchoscopy requires special bronchoscope, and this is a drawback because it's not easy to get more bronchoscopes. White light bronchoscopy utilizes the visible light of wavelengths between 380 to 720, while the autofluorescence imaging will use the 390 to 470. So we are taking a shorter range of short waves. So the blue excitation light will reach the subepithelial layer. If it is healthy, it will fluoresce green. However, if there is any mucosal changes consistent with any malignant change, such like thickening of the mucosa or increased vasculature or abnormal vasculature, where this fluorescence will lessen. Therefore, by enabling changes in fluorescence to be observed, autofluorescent imaging can assist in early detection of suspicious lesions and displaying the normal tissue in green and abnormal in magenta. This is the principle illustrated. This is the excitation light. When it reaches a normal mucosa, it will autofluoresce as green. But if it is abnormal, like it is thickened or highly vascularized, it will not fluoresce well, so the green light will lessen. And this is how we can see it with the usual bronchoscope and how we can see it with autofluorescence, but this is a normal fluorescence. This is how it is, the mucus secretions will cause a false positive result and make it look as if it is pink. And this is the loss of the fluorescence in inflammation. So it is not that accurate, and this is the drawback that led to more advancement. This is how we can see the early malignancy as a pink color in the carina. So this should be biopsied. If you see the classical bronchoscopy, it does not differentiate. So as we go on, this is bleeding, it's dark. This is a cartilaginous nodule. It proved to be very normal and benign. And this is a stenosis, a web-like stenosis, which proved benign. And this is a malignant transformation, maybe carcinoma in situ, and this is where you should take your biopsy. There are a lot of pictures, but I'll go on. This is a nodularity that is not really visible well here. Now you can say how it looks, and you can biopsy it. The thickening of the segmental carina with abnormal fluorescence due to carcinoma in situ as well. This is how the malignant tissue goes pink. I won't go all through the pictures to save time, but it looks like, if it is green, it is normal. If it darkens, it may be blood. If it comes pink, this is what you should biopsy. But it's not that accurate. As you can see here, we have the right lower lobe sleeve resection, and this is nodularity afterward. And these nodules proved to be not malignant, but the Apache abnormal fluorescence are due to secretions. So you should be very careful. The advancement that led afterwards, or the upgrade, is the narrowband imaging. The narrowband imaging is that assesses the changes in the blood vessel number and size and complexity to assess the premalignant and cancerous lesions. This was first used in the GI endoscopy, and just afterwards they tried it in the bronchoscopy to detect the vessel growth and complex vessel networks. Blood vessel enhancements is achieved by light absorption characteristics of hemoglobin. So the target is the hemoglobin. They choose two narrowband filters. One is 415 and the other is 540 to assess the mucosa, the epithelium, and the blood vessels. So visualization of abnormal distribution and dilatation of blood vessels and the mucosa in combination with high magnification will yield images of the microvasculature, more accurate, and the combination with other modalities is a must. So they should use, in the era of the NBI, that you should combine it with the autofluorescence. So they are complementary to each other. And this is how the upgrade looks like. This is the narrowband with very accurate characterization of the abnormal blood vessels and where you can safely take a biopsy. Now we come to the latest, which is the iScan. The iScan technology is a digital real-time processing and newly developed imaging. And it allows early detection, characterization, and demarcation. Those are the three magic words. You use the high definition combined with the iScan, also to detect epithelial changes. And the real advance is that you can use it on your, you don't need several types of bronchoscopes. No, it's a processor that has this high definition and iScan technology together with the high definition bronchoscope, and you can do all the things in one session. So enhancement of the tumor margin and the vessel architecture, demarcation as well, and to guide you to take a biopsy and areas to be locally treated. iScan 1, this is what we call surface enhancement, where you highlight the bronchial mucosa, the epithelium, and you can see early detection, to early detect the changes in the epithelium. While iScan 2, which goes surface and tone enhancements, you can accentuate the epithelium and the vascular patterns that underlines these epithelium. So you can also demarcate and characterize the bronchial lesions. iScan 3 further enhances the visibility of the vessel pattern and helps in localization for safe biopsy. iScan 3 tells you where safely you can take a biopsy. It is very informative in the gastroenterology. But I think when we use the iScan 2 is the best, that you can use it in bronchoscopy. iScan 3, I think it's very useful in the GI, but not in the bronchoscopy. So this is the unique high definition image that you can get. If you add an iScan 1, it will be more informative of the surface changes. This is the abnormal blood vessels. Now if you put the iScan 2, you can see the normal and abnormal and where it gets abnormal. So if it has a margin, you can see it very well with iScan 3. So this is simply how we can go through iScan. Now we will get some examples because this is the latest technology. This is a recurrent non-small cell squamous carcinoma. This is how it looks with the iScan 1, where you can see the high definition. And this is how you can see it with iScan 2, where it is accentuating the blood vessels and the architecture of the mucosa and the margins. So you can see what is normal and what is abnormal. iScan 3, it only tells you where it ends. This is what really means for iScan 3 in bronchoscopy. But iScan 2 is very informative. Now, if you see a bronchial carcinoid with an iScan, you can see it with iScan 1 where the polypoid change and the blood vessels now is accentuated in iScan 2, and this is the margin very well visualized, demarcated, so you can safely get a biopsy and accurately get a biopsy. This is a non-small cell lung cancer, adenocarcinoma by iScan. As you can see, this is iScan 1, iScan 2, iScan 3. This is the margin, this is the vascularity, and this is simply tells you where to move to iScan 2 and 3. You cannot do it all through the airways. If you can see something with iScan 1, you move and you see it with all the others. This is the adenoid cystic carcinoma of the left main bronchus. And this is how you can see the blood vessels. It looks as it is 3D. And this is where you can see where it ends. So you then take a false biopsy and you don't take a biopsy from a very vascularized area. Malignant mesenchymal tumor. This is how you can see very well demarcated edge. Here you can see the vascularity. Also an adenocarcinoma. As you can see, we have secretions, and the secretion means nothing for you, not like autofluorescence. Autofluorescence secretions will get you false results. As you can see here, this is how there are no margins, and this is what adenocarcinoma does. You can't see margins. Now they are trying to correlate the lesion and the pattern of the abnormality of the blood vessel with the type of the histological, of the pathology of the cancer. And still, this is still going on, this study is still going. And squamous, nodular pattern, vascularity, and demarcation. This is this is my case. It is the rest of the pictures. Those marvelous pictures are from an atlas of my dear Professor Erik van der Hegen of Holland, and these are his cases. My case is this one because excuse my I could not fix the bronchoscope to take a picture because most of our cases are done under local anesthesia. So this is iScan 1, and this is iScan 2, and this is iScan 2 as well, but after taking a biopsy. Look how you can see it, and I've tried to do iScan 2. After taking a biopsy, it tells you the real amount of bleeding and the real risk of bleeding. This is an option added to the technology. And this is the study or the research that is going on because they are trying to get a clue from the pattern of the abnormality of the vasculature of the tumor, and does it correlate with the type and the pathology? Thank you.
Well, I can see some of our colleagues from the next session from the ICU are here among the audience, as well as the chairpersons. I want to explain to them that we started half an hour late. We have been able to cut the time so we can close the gap. I'm going to try to continue to be as fast as I can and deliver the message that I intended today, so you can start early. You're going to start a little bit late, but hopefully not more than 15 or 20 minutes late. Is there any questions to the chairpersons from the audience? Go ahead.
My question to Professor Muhammad Khairi about the rationale for removing tumor particles from healthy or from disease site and throwing them to the questionably healthy lung, the other side.
This idea is so simple, it's extracted.
The extracted after electrocautery there will be a dead tissue. If we extracted the tumor by electrocautery and remove it in a healthy lobe, the patient after bronchoscopy, the patient can cough this tissue. Even during bronchoscopy, we can extract it by or find it by the oral suction. As you know, we have two suction through the bronchoscope and the other through the oral upper airway. If we remove it and throw it into a healthy lobe, the patient can cough it later. Okay? No hazard from drop it into a healthy lobe. Cannot be lodged. Cannot be lodged in a healthy lobe because it is smooth surface and the patient can cough it. No hazard. You can extract with cryo probe every piece, and can introduce it again. The other option to introduce an endobronchial tube under general anesthesia and go in and out through fiber optic bronchoscope. But this is an easy method or option to do it. Not every extracted tissue remove the bronchoscope and introduce it again. Can, after thawing the cryoprobe and defrost, you can let the extracted tissue into a healthy lobe. Collection of these tissues, the patient can cough it later. Okay?
Okay, thank you. So we're going to start about navigating the airway. Before we start navigating the airway, we need to go to the basics of the airway. I can't use the arrow keys or the page down. Muhammad, I can't move. I did? Oh, okay, now it's... All right, so Nether had depicted the bronchial airway for us several years ago. The way I like to look at it as a pulmonologist is where I'm standing. I know some of the audience do their bronchoscopy from front of the patient. But in the US, most of us, not all of us, but the majority of us do the bronchoscopy from the rear. As we go through the right main stem, we see the right upper lobe, and then we have the RB1, RB2, and RB3. As we move forward, we see the three openings for the middle lobe, lower lobe, and the superior segment of the lower lobe. Then we get to see RB7, RB8, 9, and 10. This is the CAT scan image as we move down in the trachea, how the trachea starts changing its shape, and this is how it looks endoscopy. When we take the cross section, we can see that right upper lobe, the right carina 1, and we can see the RB1, which is right here, in here. We can see the LB1 and 2 in that level of the CAT scan and at that level of the bronchoscopy. This is the interesting sign for the upper lobe, RB1, RB2, RB3, and this is the superior division of the left upper lobe, the LB1 and 2. Continue our cuts and continue furthering down. What I try to do here is I try to present the relationship between the CAT scan, and when we look at the CAT scan, this is below the carina, and we can see our image here, and we can see our LB3, we can see the lingula, same thing, we can see the lingula right here. Same imaging, moving on toward the right middle lobe on the right side and to the lingula. In the right middle lobe, we have the lateral segment, which is RB4, and the medial segment, which is RB5. On the lingula, we have the superior segment, LB4, and the inferior segment, LB5. As we move down, we see the characteristic three signs that looks like close or similar to the right upper lobe and the LB6, which is the superior segment of the lower lobe. As we move down further, we have 7, 8, and 9. In this picture here, this is 8, 9, and 10, and this is 7. Interestingly, that RB7 is not found in every patient. This is some of the variation in the anatomy. But if it's found, it's usually in this position. Same thing here, we have LB8 and 7. The anatomy on the left side, as you know, it's a little different. LB8 and 7 together, and then LB9 and LB10. On the CAT scan, we see them LB10, LB8 right here. Now we navigate in the airway from inside. We're going to navigate the airway from the outside. What's very important for us are the lymph node stations. We have talked about the staging the tumors, the cancers. So one of these stations that we look for is the 2R. What I depicted here is the usual bronchoscopic image, and then with this image here, it is flipped. It's not the way that you usually use it. Right is here and left is here. So you can imagine when you go with the EBUS, you're going through the trachea, and then you're looking somewhere between 12 and 1 o'clock if you're looking for the 4R lymph node. For the 4L lymph node, it's in the opposite side. So it's on the left. When I flip the image, just the way I'm doing the bronchoscopy, I like to look at it this way. Usually when I get my CAT scans, I get them in both. I get them the conventional CAT scan, and I get them the flipped images. The next one is a 4R, and what's very important here is to know the anatomy between 4R and 10R. The azygos vein is in between on the right side. So when you're going, if you see the azygos vein, any nose above is going to be the 4R, anything below will be the 10R. 4L, it's not the aortopulmonary lymph node, it's 4L. And generally, I see the pulmonary artery behind it. I see the aorta, and then I see the pulmonary artery. I know that I went a little bit too far, then I go back. That's my technique in doing it. I go far, and then I come back. 10R, it's right at the carina here, where you have the azygos vein. Once you pass the azygos vein, the first lymph node that you're going to see more anteriorly between the carina and the upper lobe is going to be the 10R. I'm going to skip the rest because it will be a redundant repetition, but now I'm going to move to what's next. Now we know the basics and analyze the scan and analyze the lymph node, and we need to go to bear with me for a second. This is a system called navigational system. For the navigational system to work, there are two navigational systems are on the market right now. One is made by Viren and one is made by Super Dimension. The Super Dimension technology has been the oldest on the market. It has been there since 2005, 2006. Viren soon followed. Okay. I'm going to continue to talk till he fixed the audio visual. So the initial system that we all have used was the Super Dimension. With the Super Dimension, they used a board underneath the patient because it used the current that it was used, I think it was an AC current. That's why it had to be underneath the patient. And for us to be able to use, that's kind of a stationary system. We can't move that system from one room to the other because the room has to be mapped. You have to get rid of any metal in the room or the majority of the metals that are going to be in close proximity to the board. The Viren, it's interesting because they used an AC current and basically they put fiducial markers on the patient from the front, and the electromagnetic generator is in the front of the patient, similar to the fluoroscopy equipment. So this system is interesting because you don't have to map the room. It's coming from the top because of the change in the current that they used. That was the first interesting thing with that system. Now I'm going to show you what I do generally. I select one of the patients to analyze and see what I can do and I need to do. And I try to do that before the lecture, but sometimes when the computer is down, it just forgets the work that was done. We need to get an inspiratory and expiratory scan. When we have those, we can match between the two. If you think about it, generally, when we do our CAT scan, the patient is not sedated, the patient is quite awake, and we ask the patient to take a deep breath in and hold it. How many of you would think that the nodule will move when we do it under sedation? With under sedation, we are at a minimum tidal volume. So we're not actually, even we're getting where we want to think that we're getting, we're still not getting there accurately. There is a room of error. So after I get the two scans, I can start reviewing the image from top to bottom, looking for the nodule, and making sure that I have all the cuts that I needed from the anatomy that we talked about earlier. This is the sensors that's sending the signal. That's done generally either when the patient is doing the CAT scan. If it's not done, then to substitute that, we take the inspiratory and the expiratory scan. I'll go next. And at the next, this is something that I had mapped earlier. You can see that there's a nodule here. I can drop a seed here for the nodule. And when I drop it, it's going to do nodule segmentation. And what's interesting, you can see here in the bronchial tree, it gave me the most recent nodule that I added here. With the 3D, it allows me to flip the nodule, to flip the tree, look at it from a 3D way, and see, is this the shortest way to get to that nodule or to that nodule, or I need to do something different. Now we're done with that one. I'll go to next. Now, it created a virtual bronchoscopy for me here. Next. Now, if I move this here, this is not the best image, but it can show you how much the nodule is really moving with inspiration and expiration up here. I wanted to go through several cases, but because of the lack of time, I'm not going to be able to. But if you want, we can ask the organizing committee to have a session, like maybe after dinner or after lunch. Now, the other analysis that I do is I bring the image here, and then I look at it too in different ways, either superiorly from the head or inferiorly as we conventionally look at the CAT scan. So you can see here too how much the nodule is moving in relation to the bronchial tree. That feature is not available in any other electromagnetic navigation, to my knowledge, up to date. I'm sure that a lot of companies will be working in something similar, but not yet. Once we get here, this is another feature that the system is very interesting. And again, everything I'm presenting is not for every patient. This is one of the systems that allows us as chest physicians who always access the pleura, is if we can get to the nodule through the airway, we can do the skin perk and we can do our percutaneous. The advantage that it gives us is that with this system and with the knowledge and the training, we can acquire the transthoracic biopsy without having the need for the actual CT. But again, it's not for every case. I'm ending here. If you have any questions, I'll be more than happy to take them. Sorry for rushing, but time was an essence here.
Thank you, Professor Ala. I think it's this session has come to an end. Do you have any questions?
At time of the procedure, it's very short. It can be done in about 15 to 20 minutes compared to the Super D, because the time of the planning, I plan it before I go to the office, so usually it takes me about 10 minutes to plan. Yeah, 10 minutes and 15, so it's about half an hour.
In this case, is it better to do transthoracic or is it very difficult? The chest wall?
Again, it's an individualized decision. If I can go into bronchial tree, I'll go bronchial tree first. But if it's a big lesion and I can do it transcutaneously and it's faster, then I will do it. If I have lymph nodes, then I would like to diagnose and stage at the same time, so I'm not worrying about the primary as much. Yeah. But again, it's an interesting concept. Most of my time, I have used the planning station alone, not having the whole system, just to analyze the CAT scan before I go to the procedure. And I generated the virtual bronchoscopy, and it did help. I diagnosed a lot of cases. If I find a bronchus sign, which is a bronchi leading to the lesion that I'm going to biopsy, most likely I'm not going to use any of the navigational guidance. I will use the analysis, but I'm going to use the regular forceps. Unless I get negative results, then I will try to do the navigational. Single procedure, it's not much. It's about a couple $100 above the regular needle, or the regular forceps, or the regular brush. How much is the regular needle?
No, for this case, how much is this?
No, how much is the regular needle that you use? $100 for the needle. It's going to be about $300 for the needle here in this case. Just the needle. No, the CT you get it from radiology, so the CT is for free. If you want just to have the planning station, the planning station is being sold alone. But if you like to have the full system, that's a different pricing model. Yeah, it gets pricey. Yeah, it gets pricey. But again, for the cost, there are multiple factors that are involved. If you have the fluoroscopy, there are lesions that you can easily get them with the fluoroscopy. But if you can't get them with the fluoroscopy, then you can try the peripheral EBUS probe. If you can't get them with the peripheral EBUS probe, because the EBUS probe doesn't cost you much. I think it's about 2,500 cases. If you really take care of the probe, you can get to 3,000 cases.
دكتور علاء الوقت بس for the next session we can continue the discussions at side discussion. I will call for the next speakers, but I want to announce for 30 seconds that we have a visitor, Professor Nazarino Gali, is coming to the military hospital at 18th and 19th of December. So you are all invited to attend. His course will be held at here in Fairmont at 18th, and the next day will be the hands-on and in the cath lab in our hospital, Military Chest Hospital. Thank you very much. Sorry for the delay.